On our concluding few minutes, I'd like to just ask each of you to talk briefly about kind of where you see treatment headed in ALL. And it's been a very exciting time in the last few years, seeing all these new agents approved in both ALL and some of the other diseases we deal with. Jay, start us off with your thoughts about the future. You've done so much great work in CAR T, and that's been a real major breakthrough.
Yeah, I mean, I think for AL in general, I mean, I think this AL is always easiest to cure the first time. So I think that my big point, and as we're all doing, is trying to incorporate this very new good therapies in the early lines of a setting. Even as the therapy is getting better, since we're still dealing with 40% of the patients not being cured with the current regimens that we have now. So already, as you alluded to, blinatumomab, inotuzumab is moving earlier. So I'm hoping the same thing will, and we'll see what the outcome hopefully will improve incorporation of these agents too. So I'm hoping that for the CAR T cell therapy targeting CD19 will be certainly kind of the moving to the front line and earlier lines of a setting, lower burden disease. And if it works well, and that potentially we have to prove, and the pediatric data will be informative about the kind of post-consolidation, what to do after they receive CD19 CAR T cell therapy and has a great response, MRD negativity or even NGS negative. Now, what do we do now? Should we just observe those patients, or should we still be thinking about transplant or not? So obviously, it's a question now. Hopefully, in the future, what the envisioning is that they can receive this kind of the one infusion of the cells, or kind of the very potent therapy, and then they don't have to kind of go through years of a maintenance therapy or some consolidation, so that we can minimize. And so I think that will be exciting, and hopefully we have a little bit better therapy for the TALL patients as well, because I think that's been really challenging. But there are also, that we heard a little bit about, the CAR T cells also targeting some of the T cell antigen. Certainly not as straightforward, but I think that also kind of provides some glimpse of a hope for those, the more difficult to treat patient population as well.
Do you think off-the-shelf CAR T are going to solve some of this processing issue that we deal with some patients?
I think it will provide certainly some for those patients, because not everybody is able to go to CAR T cell therapy, and it may overcome some of the limitations of T cell quality or the potency, or the issues with the patients. Certainly for those patients who have had a lot of the chemotherapy to begin with, so it may overcome that. And then because of immediate availability, it does make it, I think, incorporate into the earlier lines of a setting too, as opposed to waiting collection, and then you have to somehow come up with a way to maintain that MRD positive or MRD negative state before you give the CAR T, autologous CAR T. But the allo CAR T or the off-the-shelf or other cellular therapy that's immediately available may have advantage of using it kind of the right then, as we are doing with some of the BiTEs and ADCs now. And so they may, obviously we have to see the clinical trial, but I think that immediate availability provides a kind of the good ease of incorporation into the earlier lines of therapy, certainly in the MRD setting too.
Ryan, you're?
Yeah, I agree with virtually everything that Jay said, and I certainly wouldn't disagree. I think for me, better understanding of different molecular subtypes and knowing what to do with them, whether it's targeted agents, as the COG is doing for the PH-like ALL, maybe teasing out new molecular pathways that can be exploited in T-cell ALL, that hopefully by introducing some of these drugs, whether it's the immunotherapy agents we have currently or targeted therapy down the road, we can start to spare some of the side effects of the cytotoxic chemotherapy. And then also better understanding of the MRD techniques that we have, when to check, how to check it. Those I think will hopefully then allow us to more individualize patient-making decisions, so we're not having to just lump all of the pH positives into a big bucket and transplant them all. So,
yeah. Rachel,
yeah.
Your thoughts?
I think the pie in the sky view is that can we stop pounding kids with so much chemotherapy and replace it with some of these better tolerated agents? And I think 1331 is an excellent example of that. In the highest of high-risk patients, you've removed blocks of intensive chemotherapy and replaced it with an immunotherapy and had better outcomes, not just equivalent, better, not only in terms of tolerability, but activity. And so I think that's very promising. I think what we've learned with the last few iterations of clinical trials in the Children's Oncology Group is that we've hit the ceiling. We can't just improve outcomes further by further intensifying therapy. So we have to use different agents that act very differently, and that's where the timing of immunotherapy sort of coming on the scene right now is so exciting, I think. So I think for now we'll prove in the upfront setting that they're effective, but ultimately can we take out some of those really toxic and long-term side effect inducing elements of therapy and replace them with these agents?
You all have done such good work with manipulating chemotherapy, but you know, and changing the schedule, changing the doses, but we're reaching the limit there as well. I mean, I think of acute promyelocytic leukemia and how that was the worst prognostic acute leukemia, you know, 30, 40 years ago, and now it's the best prognosis, and we're not using chemotherapy. And I think I see us moving in that direction in pH-positive ALL, and I think with the pH-like and some of these agents, we're going to be in that direction as well. So I think the future is bright. Well, I want to thank you all for this very engaging discussion. And on behalf of our panel, we hope that you found this peer exchange discussion to be useful and informative. Thank you.